Well, thank you for the opportunity. I enjoyed looking back to the history, and where I'm going to start is the very beginning. So, the history of the trauma service really began with Dr. Ben Eisman, who was the first time chief of surgery here at the hospital. And he hired me in 1976, right out of my residency, to develop a trauma service at this hospital. Now, Dr. Eisman was an incredibly unique individual. He was really a visionary academically. And he was actually the chief of surgery here in Denver at the VA and then became chairman at the University of Kentucky. And interestingly, as you can see on the left, of the first 7 appointees, they all became chairman of surgery. So an amazing guy with recruiting and a visionary. Well, he came to the Denver General Hospital and became the first full-time academic chief of surgery in 1976. And he soon recognized that while we had great opportunities here, that we really needed to focus on trauma because we'd not had a previous trauma service. And not surprisingly, public hospitals, and I think they still should be, so-called city county hospitals, were the first trauma centers. The first 2 are in San Francisco and in Chicago. But we followed shortly after in 1976. Now, what drove trauma centers in the United States? It really was the violence related to gang wars, and particularly penetrating wounds. This patient here, actually I looked up in the records, was from 1978. Sort of a typical gang shooting. This guy was shot 9 times, and you can see in the heart, major blood vessels, liver, pancreas, and he survived. But these are kind of injuries we used to confront here with the drug wars. And in fact, the Denver General Hospital was highlighted in the text called the Knife and Gun Club. So Eugene Phillips, seeing all the violence around the country, came to this hospital and did a documentary on trauma in urban centers. So with that background, you can understand that the concept of the trauma surgeon would be someone who could manage all these injuries and not rely on consultants, because there is no time, as you saw in that individual, with holes in his heart, vena cava and liver, to call in vascular and cardiac surgeons. The trauma surgeon had to manage it. So the concept of the so-called trauma surgeon was the ultimate general surgeon at that time, that they would feel comfortable in taking care of all chest, abdominal, and vascular injuries. But to add to that, what made us unique compared to our counterparts in Europe is we really got involved in critical care. This is fundamental to being a trauma surgeon. So we learned about oxygen transport, metabolism, immunologic response, and particularly one of our interests here was coagulopathy. So this was the genesis of how we developed the trauma surgeon here. So here's a typical weekend. This was actual weekend when we wrote a review article a number of years ago. A typical trauma surgeon when we first started. So on Friday night, this is a gunshot wound to the left subclavian artery, now actually mostly treated by endovascular. And we opened the chest and fixed the artery, and the next patient came in a motorcycle crash, open pelvis, major splenic injury, took out the spleen. And then Saturday morning, the medical service calls and said, we got a patient here in sepsis and had a rotten lung, so we took the lung out. And that afternoon, they discovered a patient didn't have pulses in the leg, and they flipped an embolus from the heart. So we took that patient to the operating room, took clot out of the femoral artery. So this is sort of typical surgery we did at the beginning of the trauma service at our institution. Now, additionally, and again, I would give Dr. Eisman the credit for this, we very early on began a very active research program. And he made the point that this needed to be translational. We just couldn't be over the lab knocking off rats. which as you see up in that right corner was me when I first started. Little change in hair color. But we had to take what we learned in the ICU emergency department, then do experiments, and then come back and test that theory out in care of the injured patients. And in fact, very early on, with the arrival of Dr. Alden Harkin, who integrated us very shortly with the university, we became a research program funded by the NIH, and have received funding from the NIH for the ensuing 36 years to do research. So that was really in the culture of the trauma surgery program at our institution. We argued that the safety net hospital, the old city county hospital, was the ideal model for trauma and acute care surgery. So what I developed was a service of 6 full-time trauma surgeons, and we did all the surgery. Actually, to become competent in areas in elective surgery, we used to have what was called the big OR book, and we take it to the clinics, and all the big procedures like Whipple procedures, esophagectomies, we'd rotate around the 6 surgeons. So we did an equal amount of major elective surgeries so that we would become competent in the event there were injuries. All of the staff I hired here had done not only critical care fellowships, but also had done 2 years of basic research. That was fundamental to preserve our research program, but I always argued that individuals trained in basic science are curious and always want to question why we're doing things. So it fit in well to our model because we wanted to unify treatment here and study anything that needed to be changed. And we as the 6 all did emergency surgery and elective surgery evenly, and there were no cardiovascular programs here or transplant programs, so there's no competition. We did it all. I asked her, how could you do this? Well, the fact is, when you look at the timing of operations then, and probably is similar now, during the quiet hours of the day, so-called 6 p.m. to 5 p.m., that's when we do, our emergent surgery and elective surgery. The trauma really sort of dribbles in during the day. We rarely have major trauma during the day, but certainly when the sun goes down, that's when the trauma rolls in. On the other hand, that's when we don't do the emergent and elective cases. So it fit in nicely with being able to do all these things as a so-called trauma surgeon. So this was a typical profile of what we did in the early years. This is a so-called trauma surgeon. Interestingly, nearly a quarter of our operations were open vascular repair, 15% thoracic. Another quarter are really advanced, so-called alimentary, and so that include Whipple operations, esophagectomies. And only a quarter are really what we do now more commonly as a trauma surgeon, that is cholecystectomy, appendectomy, small bowel obstruction. So you see the array of operations we did and how that kept us prepared to take care of critically injured patients. So what's the evidence that this worked? Well, this was the first time the American College of Surgeons did a national analysis of outcome. The so-called research document that the American College put out that set the criteria for a trauma service for the first time looked what's the outcome and how can we justify certifying trauma centers. And remarkably, and I was obviously pleased to see this, you can look on here, we were number one by a large major. And these are all the major level 1 trauma centers in the United States. And in fact, the chance of dying if you came to our hospital compared to someone else was 0.4. That is, you had twice the chance of survival here as you did in other hospitals around the United States. So that's the beginning, and we've tried to continue on those commitments, and I'm proud of the trauma service now, but that's how we began.